Hello everyone. We'll be discussing about a journal early active mobilization during mechanical ventilation in the ICU. This was recently published in NEJM, the team trial. ICU acquired weakness is a major contributing factor to poor outcomes after prolonged invasive mechanical ventilation. It develops in almost 40% of the patients. Immobilization is a modifiable cause for ICU acquired weakness, and it has been shown that early activity and mobilization is safe and feasible in ICU. But previous studies examining early mobilization have shown conflicting results. Till now, we don't have any sufficient evidence to change the clinical practice. This study was done with a hypothesis that in ICU patients expected to require prolonged invasive mechanical ventilation, early activity and mobilization increases the number of days alive and out of the hospital to day 180 when compared with the standard care. This was an international multicentric randomized control trial which was conducted in 49 hospitals in 6 countries from February 2018 to November 2021. Inclusion criteria for this study: adult patients who are on invasive mechanical ventilation for 24 hours or more and expected to undergo mechanical ventilation beyond the calendar day after randomization, and with a sufficient stable condition to make mobilization possible. So cardiovascular stability was defined where there is no bradyarrhythmia requiring treatment, heart rate of less than 150, lactate of less than 4, combined vasopressor, that is NOR ADR and ADR infusion with a rate of less than 0.2 mics per kg per minute. Respiratory stability when FiO2 is less than equal to 0.6, PEEP of less than equal to 16, respiratory rate of less than equal to 45, and no requirement of prone ventilation or ECMO. Patients who were dependent for activities of daily living in the month prior to the current ICU admission, patients with documented cognitive impairment and suspected or proven acute primary brain pathology, that is traumatic brain injury or stroke patients, were excluded from this study. Patients with spinal cord injury or other neuromuscular disease which will result in permanent or prolonged weakness, patients with a rest in bed orders and life expectancy of less than 180 days were also excluded from this study. Patients randomly assigned in a 1:1 ratio to receive early mobilization or usual care using a centralized web-based interface. Allocation was done using permuted block randomization method with a variable block sizes stratified by site. Blinding of mobilization is not possible. However, trained staff who were unaware of the trial group assignments ascertained the patient reported outcomes, and the statistical analysis was performed in a blinded manner. Prior subgroup analysis subgrouping was done using pre-hospitalization disability level, age, illness severity, diagnosis, and the frailty score. The intervention was done according to the Medical Research Council guideline for developing and evaluating a complex intervention. A mobility team was there which comprised of senior ICU physiotherapist, health assistant, and ICU bedside nurse. The job of the team was to complete all early activity and mobilization interventions. The intervention was started immediately after randomization, that is on day 0. First, patients were assessed by the ICU physiotherapist using the ICU mobility scale to determine their highest level of mobility. And the highest level was provided for as long as possible before step down to the lower level if the patient become fatigued. So like this, after meeting the randomization criteria and with adequate physiological stability, first the physiotherapist assessed the highest level of mobility. So this was done using a ICU mobility scale which varies from 0 to 10. So 0 is no activity and lying in bed, and 10 means walking independently. And accordingly, the highest level of mobility was given as long as patient is not fatigued. When patient became fatigued, then it was stepped down to a lower level. And in the usual care group, patient received the level of mobilization that was normally provided at the ICU. All patients received the trial treatment while they were in the ICU for up to 28 days after randomization. Coming to the outcomes, primary outcome was number of days patients were alive and out of the hospital at day 180. Secondary outcomes were a mortality at 180 days, number of ventilator free days, days out of the ICU from randomization to day 28, quality of life and function in survivors at day 180. Pre-specified serious adverse events were fall to the floor, cardiac arrest, AF with fast ventricular rate, SpO2 of less than 80% for more than 3 minutes, unplanned extubation and removal of IV line. The sample size calculation was done using data from the pilot RCT done by the same group of author and using a type using a type 1 error of 0.05 and a 7-day difference between the groups and allowing for 5% loss to follow up. Sample size was calculated to be 750 to provide a 90% power. Primary analysis was done by intention to treat analysis. So total 10,828 patients were assessed for eligibility, out of which 9,736 were excluded. Finally, 750 underwent randomization into two groups, 372 to the intervention group and 378 to the usual care group. And then after exclusion, 369 in the early mobilization group, 369 had the primary outcome available at 180 day, whereas 364 in the usual care group had the primary outcome available at day 180. The baseline characteristics were similar in both the group. The mean age was 60, female patients were 34% and 39%. The frailty score, which was measured on various scale. So the median score on the clinical frailty was also similar, 3, both the group, which varies from normal range is 1 to 9. Median score on the functional comorbidity index was 2 for both the group. WHO disability assessment score was 10 and 8. The maximum is 48. And highest score on the ICU mobility scale in week before ICU admission was 9.9 and 9.8. Median interval from hospital admission to randomization was 88 hours versus 81 hours. Interval from ICU admission to randomization was 60 hours and 61 hours. Most of the patients' diagnosis was sepsis, followed by trauma and COVID-19. So, in the early mobilization group, 86.5% patients were assessed by a physiotherapist on day of randomization, and in the usual care group, 73% of the patients. Number of days per patient when physiotherapy assessment occurred was 94% in the early mobilization group versus 81% in the usual care group. Number of minutes of active mobilization per day was 20.8 versus 8.8. The mobilization milestone achieved was also similar in both the group. The median peak IMS was 6. Coming to the primary and secondary outcomes. So primary outcome, that is the days alive and out of hospital at day 180, was 143 versus 145 with a p-value of 0.62. No statistical significant difference between two groups. Secondary outcomes, that is mortality at day 180, was similar. Median number of ventilator free days, median number of ICU free days were also similar in both the group. The functional outcomes in survivor at day 180, which was assessed using various scale, was found to be similar in both the group. Adverse events, patients with more than one adverse event due to mobilization was 9.2 in early mobilization group versus 4.1% in the usual care group with a p-value of 0.005. So this was statistically significant difference found, and it is higher in the early mobilization group. And serious adverse events, that is which was already defined, so it was similar in both the group. Process of care received for those patients were also similar, like number of tracheostomy, neuromuscular blocker use, reintubation rate, use of renal replacement therapy and steroid use were also similar in both the group. There was no difference found in any subgroup. So, in this international randomized controlled trial involving adults who were undergoing mechanical ventilation, the number of days that patients were alive and out of the hospital at 180 days were similar in the early mobilization group and the usual care group. Adverse events and serious adverse events were reported more commonly in the early mobilization group. Limitations for this trial. So, the usual care group received a higher level of mobilization. Physiotherapist assessment was done in 81% in the usual care group versus 94% in the early mobilization group. So, lack of separation in the treatment exposure between the two groups might have contributed to the negative result for this trial. And whether this type of usual care strategy reflects the current practice in other hospitals is doubtful. And no detailed document was available regarding the rehabilitation which patient received beyond the ICU. So, adult patients undergoing mechanical ventilation in the ICU, increased early active mobilization did not affect the number of days that they were alive and out of the hospitals as compared with the usual level of mobilization received in the ICU. Thank you.